So I took out the PET because I thought it's getting too much if I talk about all of it. Still enough to talk about. And I also like to start first with the biomarkers that we could look at with MRI or with PET. And so one challenge, for instance, for MRI is how we could detect those biomarkers. And that can be done by the use of molecular contrast agents that would give us information, for instance, about endothelial dysfunction by measuring albumin, or for instance, looking at endothelial activations by imaging selectins or integrins, inflammation by targeting macrophages, or for instance, extracellular matrix remodeling by imaging collagen or elastin. I don't want to talk about the contrast agents, just introduce the sequences that we can use to visualize and to quantify such contrast agents. And then there's also the pathologist's view. So they usually basically cut through the vessel and get these nice images like here. And here you see, for instance, a thin fibrous cap overlaying a large lipid core. And if such a cap ruptures, usually a thrombus develops and blocks the coronary artery. And using this approach, we can, for instance, think of morphological imaging techniques that we could develop to, for instance, the image remodeling, but also to image, for instance, the growth of new blood vessels into the plaque, or, for instance, sequences that can identify the lipid core. So very important in atherosclerosis research is, or in MRI research, is signal quantification, and this can be done using pulse sequences that specifically measure T1, T2, and T2 star relaxation times. And that then allows, for instance, to quantify or to differentiate different tissue types based on their differing T1 and T2 star relaxation times. For instance, T1 mapping can be done with a saturation recovery sequence. The advantage of this approach that it's heart rate independent, because we always saturate the magnetization and start at zero. So even if there are arrhythmias, this wouldn't affect such a measurement. And what we do is we basically measure the relaxation curve and acquire several images in subsequent heartbeats. So for instance, here's the saturation pulse. Then we do the imaging right after the saturation pulse. In the next heartbeat, for instance, we could move the saturation pulse, image here on this curve, and so on, move it further, and thereby sample the whole curve and get the information that we need in order to determine the T1 relaxation time. And using this information, so basically if we can measure T1, we also can work out how much gadolinium we have in the tissue if we know the R1 relaxivity of the contrast agents that we are using. And for instance, such a sequence was implemented for coronary artery imaging. So this is, for instance, here the cross-section of a left coronary artery. That's in the pig model, and here you see the accumulation of a target-specific contrast agent. And now with such a mapping sequence, it's possible to measure the T1 relaxation time pre- and post-contrast administration. And using the previous formula, we then can basically calculate how much micromole contrast agent accumulated in such a vessel wall, which gives an indication how much remodeling is occurring under these conditions. Another sequence that is often used is the inversion recovery sequence. So there we have a 180 pulse, flips the magnetization, let's say from plus M0 to minus M0, and again then we just measure the relaxation curve and also estimate the T1 relaxation time. And if we plug it into this equation, again we can estimate the gadolinium concentration in the tissue of interest. And the way it looks like, you get several images, and using those images, basically, and if you do a proper fit to this equation, you basically can derive the T1 relaxation time. The R1 of the contrast agent can be determined, for instance, if you image Servier tubes with different contrast agent concentrations, as shown here, And since it's a linear relationship, basically it's easy to estimate the R1 relaxation time of a specific contrast agent. And this, for instance, can be then used to quantify, in this case, for instance, the fibrin content in a deep venous thrombus. For instance, this is a model of DVT, and this is day 2, 4, 7 until 21, post-induction of a deep venous thrombus. And you can see here with T1 mapping how you can basically now quantify the fibrin content. In this case, there was a fibrin-specific agent being used, and you can see it nicely correlates with histology. Another important number in MRI is the T2 star relaxation time, and that's usually important if you work with iron oxide-based contrast agents. And in order to measure T2 star, we usually use multi-echo sequences, and we sample basically several echoes, and that allows us basically to estimate the T2 star, thereby very similar to T1, work out the contrast agent concentration in the local tissue. So basically we have here the same relationship. Now we just write it for T2 star, and again we can basically estimate the gadolinium concentration. And for instance, one example, for instance, is mapping of the iron content of a deep venous thrombus. So it's the exact same model. And now here you can see, for instance, a T2 star map, and you can see how basically the T2 star varies basically or changes during the resolution of a thrombus. And this is also quite important information to make clinical decisions. Another way is to use contrast weighting, so not contrast quantification. So we also can acquire T1 weighted, T2 weighted, and proton density weighted images. I would say that was pioneered by the Seattle group for carotid plaque imaging. So here you see T2 weighted images, proton density, and T1 weighted images of a complex carotid plaque. And this information then can be used to characterize those plaques and to identify, for instance, lipid core or the fibrous cap thickness, or even the presence of a fibrous cap. Such a sequence usually looks like this. So we have several prepulses, and we usually use black blood prepulses that can be a double inversion or quadruple inversion. Could be also a diffusion-like pulse. It's this is basically a T2 prep with gradients in between, and then can be combined with tubespin echo imaging or also with gradient echo imaging. And this is the case now for T1 weighted imaging, where we usually image every heartbeat, or if it's non-triggered, usually the TR is between 300 and 500 milliseconds, and the TR is usually shortest. So the double inversion prepulse works as follows. So we have a non-selective 180 pulse that flips the spins from +1 to -1. Then we have basically relaxation, and immediately afterwards we apply a slice selective 180 pulse, which reinverts the spins in the slice of interest. So basically there we get a signal basically from the tissues in the slice of interest. However, basically the inflowing blood only experiences the first pulse, and for that reason basically we can image when the MZ magnetization crosses 0, and we get a black blood image, as basically shown here. So you can see here the blood on those images, it appears black, whereas, for instance, in this case, a hemorrhage on the T1 weighted sequence appears bright. Another method is the quadruple inversion recovery sequence. There we use basically a train of 2 double inversion pulses. And what happens to blood is it experiences 2 180 pulses. And now the beauty is that we can null basically a wide range of T1 relaxation time. So we can null basically the blood signal before and post contrast administration, so which is quite important. For instance, here you see a scan pre and post, and using the same settings, basically you can null the blood while you still get signal basically from the tissue that you had reinverted with the slice selective pulses. And this is another black blood pulse. It's, as I said, it's based on a T2 prep3 pulse, which is shown up here. But if you place gradients in between, you can see if you have static spins, you basically have a linear phase accumulation. If you have moving spins, it's quadratic. And what happens if you plot now the phase of these spins during the echo, so basically the static spins basically have zero phase, so you get a strong signal. However, the moving spins accumulate the phase, and you won't get a signal from the moving spins. Thereby, you suppress basically the blood signal. And this is an example. So this is a double inversion sequence, and you see here some Plaque mimicking artifacts. However, if you use now this motion sensitized sequence, you see you can much better suppress the blood signal, and that also can be extended to the coronary arteries. And if you want to perform T2 weighted imaging, it's basically the same sequence. All we change is we image every other heartbeat, and we use a longer echo time, usually between 50 and 80 milliseconds. And for proton density weighted imaging, again, we image every other heartbeat, but in this case, with the echo time selected as shortest. It's just another image example where you see basically a TOF image where you see the blood signal bright, and here the T1 weighted and T2 weighted black blood image, basically with the blood appearing black due to these pre-pulses. And also a nice thing about the contrast enhanced T1 weighted sequences that you can highlight here the fibrous cap. So that is a nice feature if you do contrast enhanced T1 weighted imaging. So you can somehow try to measure the integrity of the fibrous cap. Another class of sequences are the contrast enhanced sequences, and usually we use either inversion recovery sequences or dynamic contrast enhanced MRI. So dynamic contrast enhanced MRI uses usually a steady state gradient echo sequence, which I'll show on the next slide. So first the inversion recovery sequence that is being used usually for detection of gadolinium-based contrast agents. Here you see the inversion pulse, and then the other sequence block basically remains the same. What happens is that you can now null basically the background tissue, also the blood tissue, whereas you get some signal from the gadolinium due to the shorter T1 relaxation time. And this, for instance, can be used here to now image contrast agent accumulation in a plaque. This is a gadolinium-based agent, so it's a quite nice sequence, and also can be applied to cardiovascular imaging, so it's very motion insensitive and flow insensitive. And this is just an example how you can use it also, for instance, to image coronary remodeling, again with a molecular contrast agent that binds to the matrix. But the sequence also can be used without the administration of a contrast agent, so then it's poorly T1 weighted. And what we can see with this approach is, for instance, interplaque hemorrhage. So this is a patient with a complex plaque on CT, and you see these two basically bright railroad tracks on MRI, and they are suggesting that there is some hemorrhage, which usually has a shorter T1 relaxation time due to the formation of methemoglobin. I skipped just over this one because I think this is a little bit too much for this. This is now the typical sequence for dynamic contrast enhanced imaging. So it's a steady state gradient echo sequence. Here we basically acquire every 10 to 30 seconds a steady state radio echo image, repeat this, and using this approach we can monitor the arrival of a contrast agent. But what is also important, basically, before we try to quantify, we have to make sure that the MR signal that we measure is linear in relation to the contrast agent concentration that we inject. And usually that is true for gradient echo sequences if we use the proper parameters. However, for spin echo sequences, since we use usually longer echo times, for instance for T1 weighted maybe 15 milliseconds, for T2 weighted 80 milliseconds, usually we don't have a linear relationship, maybe a linear relationship for low concentrations of contrast agents, but for the higher concentrations, we don't have this linear relationship anymore. So they are not really good for quantification. Yeah, and this is basically, again, this dynamic contrast enhanced sequence, so we can basically measure the arrival of the bolus, for instance, here in the blood pool, and the red curve is in the tissue, and using this information, we can then quantify, for instance, the plasma blood volume, or also the K-trans, which tells us something about endothelial permeability, and also about the formation of neovessels if you measure the blood volume. So in order to guide the vessel wall imaging, we usually also need a good angiogram. There are several sequences in MRI that we can use. Clinically, we usually use contrast-enhanced imaging, but there are also nice methods that do not require a contrast agent. For instance, the spin labeling methods, because they take advantage of the differences in the T1 relaxation times. And this is, for instance, one example how it can be performed. So this is, so here we have basically first a 180 pulse followed by a slice selective re-inversion pulse. So basically this is the labeling pulse, and then again followed by a non-selective 180 pulse. So the tissue only experiences the two non-selective pulses. That means our tissue is nulled at the time of imaging, and the labeled blood only experiences in some basically the non-selective 180 pulse. So basically at the time of acquisition, basically we get a signal from the labeled blood. And if we put this together, so basically we see we can suppress the signal of the background tissue while still getting a signal from the labeled blood. And this then can lead to quite nice angiograms as shown here, that you can use to guide your, let's say, the plaque imaging sequences. Another way of visualizing the blood vessels is to take advantage of the long T2 relaxation time of blood, which is in the order of 250 milliseconds for arterial blood. And this is done with using a T2 pre-pulse. So if you flip the magnetization in the XY plane, tissues with a shorter T2 decay faster, and if we then restore the magnetization, we can generate a contrast, in this case, between blood and the background tissue. And that allows, for instance, then to acquire nice, in this case, coronary angiograms that also could be applied to the carotid arteries. And as you can see here on this example, the myocardial signal is suppressed with the T2 preparation on, as shown by the arrows. In order to get good vessel wall images and also angiograms, we also need good fat suppression, and usually we use a frequency selective pulse. It only basically prepares the fat signal. Usually it's a 120 pulse, and then at the time of the zero crossing, we perform the imaging. And again, shown here as an example, the coronary arteries, and you can see if you don't perform fat separation, you see the epicardial fat. If you apply the fat set, we can remove the fat signal and get a clearer representation. And that also can be done with a different technique. It's called the Dixon technique, where we acquire 2 or 3 echoes, and usually where we acquire one image where the water and fat is in phase, and one image where the water and fat are out of phase. And then if we either add the images or subtract the images, we can reconstruct just a water-only or fat-only image and generate an angiogram, or basically also an image of epicardial fat, which may be also a risk factor for atherosclerosis. And of course, also respiratory motion compensation is very important, especially if we want to apply plaque imaging to the coronary arteries. One method of dealing with it is to navigate with the pencil beam navigator, and this has been quite successful. However, if we increase the gating window, these methods sometimes fail, and for that reason, for instance, 2D self-navigation may be more useful for larger gating windows. So basically, we start with a T2 prep to get good contrast between muscle and the myocardium. Then you basically can run the 1D navigator, fat saturation as shown before. And then basically these 2D navigators that can be extracted from the start-off profiles from the imaging sequence itself. And basically what you get then, every heartbeat is basically a low resolution real-time image that you can use to navigate your scan. And the major advantage is that you can increase the gating window or scan without the gating window without compromising the image quality. These are just some image examples how that may look like if you use those image navigators, and here with a scan efficiency of 70%. So basically a typical Lumen sequence has uses a T2 prep pre-pulse and fat suppression, and then basically a gradient echo or steady state sequence, whereas the vessel wall sequence usually uses an inversion pulse or a double inversion pulse, while the imaging part is pretty much the same, and also the navigation part is pretty much the same. So one sequence that can be used for imaging the coronary vessel walls is a double inversion sequence that is slightly modified, where the reinversion pulse is a pencil beam, and that allows then just to reinvert the signal around the coronary artery of interest, and in this case, for instance, here the right coronary artery, and it allows you to depict this quite good delineation, in this case the vessel walls of the right coronary artery, and it's acquired with the radial technique in this case to minimize the motion artifacts. Another way of imaging the vessel wall in the coronary arteries is basically by turning the T2 prep on and off in subsequent heartbeats. So basically, if you have it off, then you should get similar signal intensities from the blood and from the myocardium. If you turn it on, the signal of the myocardium is reduced, and if you subtract these images, we get basically image from the myocardium, but also the vessel wall, but we can suppress the signal of the blood. And the good thing about this approach is that it's flow independent. So, and this is how it works. Basically, you get two images, one with T2 prep on and off, and if you subtract the images, you get an image like on the right-hand lower side, where you basically have a black blood image with a nice delineation of the coronary vessel walls. So in conclusion, MRI provides many contrast weightings that allow imaging of the vessel lumen, the vessel wall, for instance, morphology, but also vessel wall vascularity, for instance, with dynamic contrast enhanced MRI. It also may provide some information on endothelial function. And on the vascular biology, we get information usually with contrast enhanced imaging in conjunction with molecular contrast agent that target, for instance, inflammatory cells, the matrix, or also the endothelial cells. And with advanced motion correction techniques, we also can then translate these imaging techniques from the carotid arteries or from the aorta in order to image the coronary lumen and also the vessel wall. Thank you for your attention.